very pleased to welcome you all to the virtual tumor board that we launch within the PCM4U program, educational program. So we have here the French precision medicine team from Centre Léon Bérard, and we have Somaya and Paula. So Somaya and Paula, you are our experts from abroad. So do you want to introduce you quickly, please? Paula, maybe.
Yes,
Paula,
Yes.
maybe.
Yes, I am Paola Zagami, a medical oncologist at the European Institute of Oncology Milan, Italy. And yes, I am focused on precision medicine and all the molecular tumor board.
Somaya.
Yes, hello, I'm Sumaya Mohammed. I'm a medical doctor in the Netherlands, and I'm a PhD candidate on the DROP trial focused on precision oncology at the LUMC in Leiden.
Perfect. So thanks a lot. So let's start. So we have a few patients. I think we have 5 clinical cases. These are virtual patients. So there are no way to recognize any real patients, but we think these are good patients to learn of how works a molecular tumor board and how do we think about targeted treatment in practice. So this is patient 1. The first patient is a patient with breast adenocarcinoma, hormone receptor positive, HER2 2+, and the FISH analysis is negative. And she has been biopsied on a sternal metastasis, 50% cancer cells in the sample. These are the previous treatments she received, and this is the results of the molecular analysis. So molecular mutational load 7.8. So our usual cutoff is at least 10, or it depends on the tumor types. And I think one of the most interested result is mutation on PIK3CA, which is a frequently mutated gene in breast cancer and many other cancers. And CNV didn't provide with very interesting diagnostic alteration, and RNA-seq were not done yet. So, Emaya, what would be your proposition of treatment for these patients?
Well, looking at the PIK3CA, it could be a target we could give targeted treatment for. But let me see. I have to check if we could give that within DRUP, because so we might have alpelisib available for PIK3CA mutations in DRUP, but this is not.
I think there were some challenges for
Yes.
patients specifically with this tumor type with breast cancer, hormone receptor positive for this cohort, isn't it?
Yes, it's true. So because alpelisib in the Netherlands is registered for hormonal positive, HER2 negative patients with breast cancer, these patients are not applicable. But since this patient is HER2 positive as well, that is something we should talk about with our PIs if that would be an option.
Okay.
So, but that's looking at the other found mutations. There's nothing we could give.
The challenge is HER2 status, given that it's ambiguous with 2+, but FISH negative. Maybe it could also go to the registration alpelisib treatment.
Yes.
Could be.
So then it would be outside the scope of DRUP, yes, of a trial.
Paula, what would be your proposition in terms of treatments or trials?
So in Italy, in this moment, we are lucky because we have a phase 1 trial that is sponsored and using drug that is an anti-PI3K, including all types of PIK3CA mutation for all hormone receptor positive metastatic breast cancer after CDK4/6 and endocrine therapy. endocrine therapy. And the patients that could potentially be enrolled.
Okay, very nice. That would be an interesting option. So we don't have this relay clinical trial. Is it RLY 2760 something? Do you have the?
Yes. No, the good option is that for these patients, there is this drug combined with the fulvestrant, so the patient could have also endocrine therapy.
Good. So you're lucky. We don't have at CLB, but other centers in France have this trial if it's the same one. In Centre Léon Bérard, we have a phase 3 trial, in fact, called EPIC B5, which can recruit patients with hormone receptor positive breast cancer. But indeed it combines hormone therapy with PIK3CA oriented treatment, match treatment. And this patient already had tamoxifen and letrozole, so that could be a challenge because it could be, I don't have the criteria in mind, but it could be an exclusion criteria to have a previous hormone therapy, at least with letrozole. So, but this is to check. And indeed, we don't have other clinical trial for this patient. So good. Any other ideas or thoughts from the team? Or RNA-seq could give also some insights, but we'll see next round if we have some results. Okay, so these were some previous proposition words that we just said. For patient 2, we stay with hormone receptor positive breast cancer, HER2 negative, and this patient has a GATA3 mutation, and we think it's interesting because it's relatively rare mutation, a gene that we don't know so much about, at least for the previous years of therapy development. But it seems that there are new drugs on the horizons. So there's also amplification of FGFR1 gene, which is quite common, could be found in breast cancer, but we'll discuss about the relevance of this alteration. So do you want to give your thoughts about these patients? So Emaya, do you want to start?
Yeah, sure. So she already has been treated with abemaciclib. Looking at the CCND1 amplification that was found, that would be a target, but since she already was treated with that, that would not be useful, so that could not be possible. But looking at the amplification of FGFR1 with a copy number of 8, while for DROP the minimal copy number is 7, so a copy number of 8 would be eligible for FGFR1 targeting. So we would be having lenvatinib or sunitinib or erdafitinib available, and based on the different cohorts that are open, we could choose one of those, or we could randomize.
Interesting that you have erdafitinib in this situation. So how much patients? I know in drug trials there are some interim analysis. So do you know more or less? Maybe it's quite specific question. Sorry, but could you?
Oh, that's fine. We have different FGFR treatments available, and erdafitinib is one of the last ones that came. So we have it for amplification of FGFR1, 2, 3, and 4. On top of my head, I would say that we have around 6 patients, 7, treated with erdafitinib, but I'm not sure by heart how what tumor types. No.
Okay.
I'm sorry, I can check.
Okay. Looking forward for those results.
Yes.
And Paula, what would be your advice for this patient?
So I'm agree because the single copy number gain about the FGFR1 genes is the most targetable in terms of evidence that we have. In Italy, we don't have anything in this moment for these types, but in our molecular tumor board, perhaps checking about the clinical trial matching tools and other stuff, we could find a drop trial and tell the patient if they want to go there. Or perhaps we could also ask for the 5%. We have found that it is the 5% of IFA, in which we can ask for some target drug for rare mutation and in an off-label setting. So it's the only things that we can tell to the patients in Italy in this moment.
Very interesting. So in France, we don't have any orientation that I could think about for FGFR1 amplification. Since still it's interesting, I think, to dig more into this targeting with FGFR FR inhibitors. There have been some literature already on that. I don't remember a specific trial with erdafitinib on breast cancer. I think there aren't, because you have a job cohort dedicated. But very interesting. GATA3, we are starting to have some treatments. So, for example, we have the Demeter trial that is about to open, or maybe really recently open in Lyon, in France. Still, this is a trial that is testing MTM2 inhibitors, if I remember well. I should have the time to check just before. And there are some rational and new trials, phase 1 trials, investigating this path for targeting. So we'll tell you if this inclusion could be managed to be done, and hopefully such results of such approach. Yeah.
We just checked last week, and there was the Megamost regorafenib should be open actually in Saint-Lambert. For the moment, it's still open, and we checked last week. So actually, for amplification of the FGFR1, we should be able to give him this type of trial.
Okay, perfect. Thanks, Gail, for the insights. Always a team effort needed to remember everything.
And the last little things regarding the laboratory parts, because it's more my field.
Yeah.
When you have a mutational load like that, 9.6, and if it's really the patient in the last option, and we don't have anything less except maybe immunotherapy, that would be great to ask the lab if a 9.6, if it's really standard, if it can be changed in 10. That way you can maybe get access to immunotherapy, because it's really close to the threshold. So
would you recommend another test to confirm, or a reanalysis, or just a re-evaluation of the
re-evaluation, and because it's a calculation, tumor load. So if 9.6, if you change the value, it's almost 10. So yeah, if we can return 10, maybe we'll have access to immunotherapy. So if it's really close to the threshold, so I don't know if it's relevant for the patient, but if really it's the last option, maybe it could be great that the lab change at least the number, just not changing it, just instead of 9.6, if you round the number, it means 10. So
So we are also evaluating some complementary. So in this case, it would be interesting to have the tumor lymphocyte infiltrate, for example. So if there are a lot of lymphocytes infiltrating the tumor, this could give another argument to go for immunotherapy. If it's very cold tumor, even with 10 mutation per megabase, maybe you can discuss more the relevance of such orientation.
And also PDL1 in this idea.
PDL1, yeah, sure. Okay, so good. So yes, for this patient, we wanted to show you. So we use trial matching tools. There is one in France. called Clineo, but there are plenty, and Paula and Somaya, you are expert also on that. So we just wanted to show that indeed this proposition was in the trial that could match to this patient. Still, these tools have several propositions ordered by the relevance, and we see that other trials are maybe not so much relevant, at least on the specific GATA mutation, GATA3 mutations, but could be also interesting if we go further in the immune analysis, so such as PDL1 or without biomarkers. This is only to show some type of tools that we can use to help. Third patient, so we changed tumor type. This is a patient with a colic adenocarcinoma. Is known so proficient microsatellite status. So stable, microsatellite stable, and wild type with on RAS gene, so the gene of the RAS family and RAF family. So this is an indication. I think it's good to stress that this is an indication of going further in the molecular analysis of such cancer type. But if there is a patient with colic cancer, KRAS mutated like G12D, it's less useful to make extensive molecular analysis. So that's a case to illustrate that. So for this patient, we found 11 mutation per megabase. But the microsatellite status that can be inferred, and Gael and Valerie are the experts, were inferring a stable microsatellite status, which were relevant with previously known analysis. Still, in this patient, there have been some mutation in NRAS and KRAS on the Q61, RBB2 mutation, and MAP2K1, so corresponding to MEK1 gene, which are many different genes on the MAP kinase pathway. So this is quite unusual case, I would say. The APC mutation is quite classical in colic cancer, and then there are other mutations with gene interesting but not very targetable. So these are the answers. But what would you propose, and what would you discuss on this patient, Soemaya?
Yes, so as you can see, so it's interesting because it was said that it's RAS-RAF wild type, but then doing more research, it's found that there is a KRAS and an NRAS mutation. So in the Netherlands, we have for KRAS mutations, we have a Sherpa trial, so it's a phase 1 trial, the NKI. For MAP2K1 mutation, trametinib monotherapy was available in DRUP, but due to slots that were available, that might unfortunately not be the case anymore. And for the ERBB2 mutation, we have trastuzumab plus pertuzumab treatment available in DRUP, but concomitant mutations in the RAS-RAF wild pathway are an exclusion criteria due to negative evidence. So unfortunately, for this patient, we would not have a treatment available because for the tumor mutational burden, we have a cutoff of 16, and this patient has 11. So yeah, no good news from our side.
So Paula, what would be your news?
Think about, if you don't have good news, think about Italy that we are without drop trial. No, also in Italy, we don't have anything in this moment. For sure, the mutation on KRAS and NRAS explain that the patient will not respond very well also to other type of treatment. But we can take in mind that there are these mutations, because I think that also phase 1 trial like open every week something new, and so we usually make also like a match about the patients that we discussed during the month in order to know if there are new trials that open for this mutation, but in this moment, nothing.
Okay, so yes, I think clearly the hits on the MAP kinase pathway make us think of what would be the best targets. So RBB2, we usually know that it's a nice target. Mutation could be discussed, at least should be oriented in clinical trials if there are some for this evaluation. But when you target RBB2, transmembrane, and you have different mutations, so activating mutation downstream of the pathway, maybe this is not the best way to inhibit the initial, so the start of the pathway. Gail, you may have some.
Yes, some
insight?
notes.
Mm.
Yes, like actually, if it's clearly circulating tumor DNA, and if we have only those information, that we have to know is the VAF, the allele frequency, because we have a lot of TP53 and KRAS and NRAS, and there could be as well hematopoietic mutation. So we are not sure for sure that it could be driver of the tumor and not a chip from the patient, because it's an old patient and he received a lot of therapy before. So before even RBB2 normally shouldn't, but we should check those type of things. And as well, with circulating tumor DNA, we see subclones, but as well, it's kind of strange to have so many drivers, and either it could be chips, or it could be as well the tumor has really a high tumor burden, but we don't see it on blood samples, and checking it on the tumor, and maybe all those mutations are just driven by a high tumor loading, could be something that we need to check before testing or putting a drug on those drivers that maybe are not really drivers at all. So I will recommend as a biologist to maybe check if those drivers are really there or just from the blood cells.
Correct.
Yeah, correct. So we didn't provide with a VAF. Sorry, that could be a good use case, but indeed, in case of high variant allele frequencies, this was probably related to chips, and then it's worth it to go to the tumor to confirm what is really belonging to the tumor. So let's say that we have RBB2 only. RBB2 mutation in the tumor and other KRAS or NRAS were just clonal hematopoiesis. We could discuss orientation to trials such as 11002, a trial that we have in phase 1, but still this question persists about MEK1 mutation. And in MEK1, we have a cohort with trametinib in Megamost that has recently closed for analysis. So this could, but by the time we discussed the patient, it was a proposition we made. And the other gene, we don't have any orientations. Okay, any other ideas or?
No, perhaps it could be helpful also to know when the blood exam was made for the patients, if it was after a specific line of treatment that they received, or for example, after the bevacizumab, the last line, because I think that also in this way, perhaps the biologists can be more specific, but we can have also different type of mutation based on the resistance developed from the treatment before. So perhaps this can help also in the orientation.
Yeah, you're right. So information are important of the sampling, of the origin, circulating that change a little bit the interpretation, and the history course of the patient. Okay, good. Nice discussion. And this is also some presentation of another matching tool, illustrations, Digital SMT, which is an open source tool that you know. For example, you can query colorectal cancer, so it's quite simple in terms of tumor type description, MAP2K1 mutation, which is the lowest in the pathway, and it outputs some trials that are relevant. This is a Megamost trial that we have in Lyon. and it says it matched to this alteration, MAP2K1, and the intervention is trametinib. So this is good. Still, there is this status of the cohort. Could we enroll new patient in the cohort, or should we wait for analysis? And in this case, we should wait for analysis. And there is another trial, KIN 2787, that was proposed by the tool. You may know this is phase 1, but just to show you that when we click on that, we go to clinicaltrial.gov, which is a reference database. And when you search, so Marine did the search, and when you search for where MAP3K1 is present, in fact, it falls into the exclusion criteria. So this is not an inclusion criteria, this is an exclusion criteria. So the message behind that is beware with those tools. It can sometimes, given how it is built, it can sometimes give false results, and we should always check. A patient with prostate cancer. So this is an interesting patient. It's quite rare, but we had this patient, so I would like to propose it to your thoughts. Prostate cancer analysis on the circulating tumor DNA, so blood again, and we found MSI high status inferred from the circulating DNA. 18 mutation per megabase, so high mutational tumor load. This correlates with the MSI high status. With the androgen receptor gene mutated, which is frequent in prostate cancer, different gene mutated, and the MSH6 mutation, where it can raise some question about the responsibility in the MSI status. So for these patients, so Maya and Paula, what would you propose? What could you propose in your countries? This is, I think, interesting.
Yes, it is. So, looking at the high tumor, at the MSI high and tumor mutational burden, that would, you probably would be giving immunotherapy. Within the Netherlands, it's at least needed to have this checked on the tumor sample. So just circulating tumor from the blood would not be enough, but probably it will be high. So based on the results of the DROP trial a few years ago, treating patients with the MSI high tumors, tumor agnostic with the nivolumab monotherapy, it was shown that it was a very good treatment, and based on that, it's now available with outside of a trial for every metastatic patient with MSI high tumor. So if this patient was in the Netherlands, he could just get nivolumab. So that would be good. If that would not be the case, there are a few more mutations found. So for the P10, we would have alpelisib available, but only if it leads to loss of function. So if it was all total loss of function. And that is it, I guess. But I think nivolumab would be a very good option.
Okay. So in Italy, so we have a trial, like a phase 1 trial in this moment that is sponsored, and also with MSI from the blood, so from ctDNA, we could propose a trial with atezolizumab plus interleukin 15 that could be a good option based on the blood tumor molecular pattern and also the MSI. For sure, also from our molecular tumor board, there will be the indication to make also in the tumor sample, and if was confirmed, perhaps also to go to a genetist in order to understand if there could be something about the family, about Lynch syndrome or other. I'm sorry that the NTR-CAP1 is not a fusion, because if it was a fusion for NTR-CAP in Italy, it's there is diagnostic approval about the entrectinib. So the first one that is good in Italy compared to the other. And if there was not the trial, we could ask for an off-label about the dostarlimab, another anti-PD-1, or pembrolizumab, but it will be a little bit not easy and fast. But yes, not other for.
So in France, we neither have access, reimbursed access to immunotherapy for MSI, nor for NTRK fusion targeted treatment.
1 and 1.
Yeah. So we need clinical trials, and hopefully we have our job, like the clinical trial MOST plus, provides a cohort for MSI high with durvalumab and tremelimumab association. So this could be interesting for this patient indeed. We have also another trial called Regomune could be proposed with durvalumab, I think. And then indeed, I would refer this patient to the geneticist for the MSH6, as you said, Paola, in order to see if the family story, see if there is a germline alteration in MSH6, and then test the family for prevention purpose. And this fusion we didn't discuss, but this is a pathognomonic fusion, TMP-RSS2 ERG. ERG is a pathognomonic fusion of a patient with prostate cancer. Any other proposition for this patient?
No, but I have just one question for Samaya, because you mentioned the P10, and just for my knowledge, do you need a biallelic inactivation, or just one hit? For example, here, a stop mutation is enough for your trials?
No, mostly we need biallelic loss.
Okay.
To really make sure that there are no copies left.
Okay. Yeah, thank you.
Maybe we'll pass this one, and our last patient. So this is a patient with pancreatic adenocarcinoma, metastatic. He already received 2 lines of treatment. And this is also blood-based analysis, if I remember well. And we have this type of mutation. So I think there haven't been the possibility to make molecular analysis on the material at diagnosis. Otherwise, we already have known that there is this KRAS mutation, which is like half of the patient with or more with pancreatic adenocarcinoma. But we have ATM and CHEK2, and that's interesting because Gael may have some interpretation out of these genes. And we have this NF2 and CDH1 mutation, and I have the VAF under my eye, so I can provide. So just to let you know, variant allele frequency of CDH1 is 94%, so almost 50%. And that's the question I may have to you, experts. And NF2 is 0.52%, so less than 1%. And TP53, 0.28%. So this is a difficult case, but sometimes quite frequently, we don't have any treatment. But for this patient, what would be your recommendation? Maybe still the same order, but maybe, Gael, you want to start concerning ATM and CHEK2.
But it's written already, so they could be from clonal hematopoiesis. That's great. So we should not consider them as for any clinical trial or any treatment.
But maybe
But
to
maybe
yeah.
if it was it depend on the allele frequency. Maybe it could be great to see what is the age of the patient, and maybe I don't know if in other countries it's the case, but maybe to follow them for hematopoietic disease, leukemia or things like that. So if you have this type of alteration, and especially JAK2 that we don't have for this patient, but maybe I don't know if you refer those type of patient to specialist expert in hematology to follow them, or do you have special way
Yeah.
to do it?
Interesting question. So Somaya, do you want to start?
Yeah, I would think that would be interesting as well. Yes, so same as the last patients for in the Netherlands, at least for DRUP, we need to find these mutations within the tumor. So based on this, there would not be treatment available. So since it's interesting that both ATM and CHEK2 have been found, so maybe if these are also in the tumor, it could also be interesting to check for HRD, because then if there would be biallelic loss of one of those, so then HRD would be the chance that you would find that would be higher, of course, and then this patient might benefit from PARP inhibition. But based on only these findings, we unfortunately would not have any treatment.
But
Clinically,
do you refer those patients to specialists in hematology? Or let's say based on the clonal hematopoiesis, do you sometimes refer the patient to hematologists for them to check if there is any leukemia disease going on or things like that?
I have to say that I'm not really familiar with this, but I could check. But I guess if someone would suggest that yes, that would be a good idea to refer them. Yes.
in Italy, I have to tell you that we base more about the clinical seeing and symptoms or other stuff to go to hematologist. But hematology is part of if we need about the molecular tumor board. So perhaps if there is this question, we can talk with the hematologist after and specific ask about that. But basically only about the clonal hematopoiesis is not our use to go to hematologist.
Any super treatments you may have access to, or is it too like classical alteration not targetable?
In Italy, in this moment, we don't have anything for these patients. I didn't listen about the VAF for NF2 because I don't know if it can be valued to understand if it's related to neurofibromatosis or other syndromic symptoms or other, I don't know.
It's
The
less
only
than
thing
1% indeed.
Okay, no, okay, no, I didn't, I didn't listen, so.
CHEK2 is less than 1% too, so it's quite difficult sometimes to really
to
be sure
define.
it's tumor or hematopoiesis.
Yeah. No, I didn't listen about the 1%, so sorry.
No problem. Okay, so difficult case indeed. Pancreatic cancer with KRAS mutation was very, very rarely. So I think 2% max. It's KRAS G12C, for which we can have targeted treatment, but other KRAS mutation we don't have yet. There are some ongoing, a lot of research, intense research. There are some trials, but I know one trial in the US with pan G12 KRAS mutations for treatment, and we tried to have it in Europe, but it's not an easy task. Still, so for Gael question, indeed, I like to ask the advice from an hematologist to be sure there is no risk, and it's good to have like a standard blood test. So if everything is normal, there's poor risk that there is an underlying hematological disease. But indeed, in JAK2 mutation could be or others could associated to abnormalities, blood in blood test could lead to indication for hematological checkup. And NF2, I'm aware, but we don't have access to 2 trials for TEAD inhibitors, so targeting this protein. This could become interesting, and this quite frequent alterations that we see in some patients. But these are trials that are not active yet, and in our center at least. It's good to keep an eye on this, because it could be an orientation for these patients that otherwise would be treated. And CDH1 was kind of intriguing with like 50% VAF. So that's just to say that in molecular tumor boards and molecular analysis, we often find some intriguing results. It's difficult to, so CDH1, I'm sure you know, this is in case of germline alteration, this is increased risk for gastric cancer and lobular breast cancers. Pancreatic cancer don't go at all in the spectrum, but it may raise some curiosity, I would say. So Gail, maybe what would be your advice on this CDH1 mutations, 50% VAF? Is it a functional mutation? Is it a unknown pathogenicity?
Actually, yeah, I need time. As a biologist, I will need time to look at this variant and to check if it's a real pathological variant or if it's just of unknown significance. But if it's a pathogenic variant, it's important to refer the patient to an oncogenicist for the patient to get extra information and maybe for predisposition. But if it's just of unknown, not really relevant, we won't do anything about this type of variant. And it's pancreatic cancer, so it's not the same thing, but when it's breast cancer, it's really important as well. And there are a lot of somatic CDH1 mutation in breast cancer, but there is pancreatic cancer. So yeah, it will really, I will need to check the pathogenicity, but if it's really pathogenic, it could be great to refer the patient to oncogenesis.
Well done. So thank you a lot.